Hi, my name is Angela and I'm a nursing student at Heartland Health Center. I am going to be presenting a patient to you today. My patient is a 63-year-old African American female. Patient is currently single and usual occupation was as security in churches and libraries and also as a cab driver. Patient has been at Heartland for a little over 2 years, having been admitted on September 4th, 2013. Patient's usual source for medical care is through Michigan Medicaid. The patient's vital signs were taken. Patient's heart rate was 90 beats per minute. Patient's respiratory rate was 26 breaths per minute. Patient's blood pressure, as taken by the morning nurse, was recorded at 114/77 millimeters per mercury. Patient's temperature was not taken. Patient's chief complaint is chronic type 2 diabetes mellitus and hypertension. I will now be giving the history of the patient's type 2 diabetes and hypertension, a health history, a functional assessment, psychosocial data, and family history. History of present illness. Patient reported the onset of both her type 2 diabetes and hypertension as 2005. Patient reported that the location of pain due to both complaints is typically in the knees, and the intensity comes and goes. Patient reports that the pain in her lower legs is constant. Patient finds sitting in her chair is something that aggravates the pain and finds that using range of motion techniques and stretching with the help of the Heartland staff as alleviating to her pain. Her efforts to treat include multiple medications and participation in physical therapy on a weekly basis. Patient is very accepting of her chief complaints, but admits that the pain does interfere with her daily activities because the pain makes it hard to concentrate and enjoy talking with others. Health history. Patient reported having the measles, mumps, and chickenpox as a child. Patient also recognized her history of chronic type 2 diabetes, chronic hypertension, and osteoarthritis. The patient's charts confirmed a history of diastolic heart failure, cholecystitis, chronic gastroesophageal reflux disease, chronic obesity, chronic diabetic neuropathy, delirium, urinary retention, hyperlipidemia, chest pain, and a history of alcohol abuse. Patient is up to date on immunizations and reported having a flu shot in February of this year. Patient's charts indicated that she has allergies to aspirins as they give her ulcers. She is also allergic to morphine, which causes itching. Lastly, patient is also allergic to non-steroidal anti-inflammatory drug as it causes her GI distress. Patient was hospitalized for a small bowel obstruction on September 26, 2014. The surgery was performed at the University of Michigan Hospital. Patient is currently taking multiple medications as indicated by her charts. An allopurinol 200 mg tablet by mouth 1 time a day for her gout. Amitriptyline HCl 100 mg tablet by mouth at bedtime for her depression. 2 calcium carbonate tablets by mouth 3 times a day for supplement. Chlorothalidone 25 mg tablet by mouth a day for her hypertension. Claritin 10 mg tablet by mouth 1 time a day for allergies. Cyanocobalamin 100 microgram tablet by mouth 1 time a day for supplement. Ferrous sulfate 324 mg tablet by mouth 1 time a day for supplement. Gabapentin capsule 300 mg taken by mouth every 12 hours for pain. Humalog solution 10 units subcutaneously injected 3 times a day for her diabetes. Held if her blood sugar is less than 200 or if the patient refuses tray. Hydroalazine HCl 10 mg tablet by mouth every 8 hours for hypertension. Hydrocodone acetaminophen tablet 5 to 325 mg, 1 tablet by mouth every 6 hours as needed for pain, held if lethargic. Lantus solution 100 units per milliliter injected with 25 units subcutaneously at bedtime for diabetes. Losartan potassium 50 mg tablet by mouth 1 time a day for hypertension and diabetes. Lovastian 20 mg tablet by mouth at bedtime related to her hyperlipidemia. Lastly, Mylanta suspension 10 milliliters given to patient by mouth every 6 hours or is needed for heartburn. Functional assessment. Patient reported little exercise other than range of motion activities due to her wheelchair-bound status. When asked about sleep patterns, patient reported that, quote, I usually get 8 hours of sleep a night, some nights not as much because I stay up late or I can't sleep very well, end quote. Patient's daily food intake varies because each day she can choose 3 different meals from a menu. On the day of the interview, her breakfast was balanced with oatmeal, juice, fruit, and toast. Patient used to smoke but currently does not. Patient doesn't drink much coffee or consume many caffeinated products. When asked about use of safety devices, patient reported use of a lift when going from her bed to her wheelchair. Psychosocial assessment. Patient has 6 brothers and a sister and reports feeling closest to her daughter and sister. Patient's biggest perceived stressor was reported as her ability to not walk in 2 years. Patient's charts indicated that she has been struggling with depression and anxiety that got worse when her brother passed away. Patient finds relief in listening to the radio and reports being very spiritual and identifies as a Christian. Family history. Patient is sensitive talking about her family, so information was gathered from her charts. Father is now deceased and had diabetes mellitus. Mother is deceased and had coronary artery disease. Sister currently has hypertension. After the interview with my patient, I performed a review of systems on both the cardiac system, due to her hypertension, and the peripheral vascular system, due to its relation to her diabetes. Upon reviewing the cardiac system, patient reported feeling no chest pain, arm, or jaw numbness. Patient reported feeling fatigued throughout the day. Patient does not experience palpitations. Questions addressing performance of activities were not asked due to her sensitivity about her wheelchair-bound state. Patient reported that her weight has remained relatively stable in her time at Heartland. Patient reported a family history of cardiovascular disease, mom with coronary artery, and sister with hypertension. Patient also reported her father having 5 strokes throughout his lifetime. Her hypertension was diagnosed in 2005, and the patient reports that the medications given for it are, quote, helpful enough, end quote. She still reports having pain related to her hypertension. Patient reports not having any infections or viral illnesses affecting the cardiovascular system. Patient has an electrocardiogram. She has had a stress test, an echocardiogram, but no surgical procedures for her cardiovascular disease. Patient responded yes to having hypertension and diabetes, and no to having a thyroid disorder. Patient does not know her cholesterol levels. Upon reviewing the peripheral vascular system, patient reported feeling pain in her lower legs while sitting. She also reported coolness and swelling in her legs. Patient reported no history of blood clots in her legs and no varicose veins. When asked to describe her circulation, patient reports feeling numbness in her feet after being left in her shower chair for too long. Patient said no to skin paleness or blue color, but has noticed her skin be more dry lately. Patient again reported history of hypertension, diabetes, but no to all other circulatory or lymphatic diseases. Patient reported yes to skin changes, saying that swelling, dryness, and shiny skin were all present. Patient notices more coolness in her legs. She reported having an ulcer before, but said that it is almost completely healed. Patient reported only having swollen glands when having a cold. Patient lastly reported having pains and cramps in both of her legs. After talking through the review of system questions with my patient, I performed physical exams for both the cardiovascular and peripheral vascular system. Cardiovascular system. Upon inspection of the patient's chest, there was no heaving or lifting over the 5 key areas: aortic, pulmonic, Erb's point, tricuspid, and mitral. The contour of the patient's chest was normal with no injuries or deformities. With palpation, no lifts or thrills were seen over the 5 key areas. When palpating the patient's PMI, the pulse was faint but still present. When auscultating patient's 5 key areas with both diaphragm and bell, only S1 and S2 sounds are present. There was no detection of any murmurs. Patient's sounds were only heard with her lying supine in the bed. Sounds could not be taken with her sitting up in the chair. I also was unable to listen for S3 and S4 sounds because patient's condition made it unable for her to roll over in the bed. The patient's apical pulse was still auscultated and findings were normal. Peripheral vascular system. Upon inspection, patient's skin was pink, dry, with no ulcers, no varicose veins, and no hair present. Upon palpation, her skin was a normal temperature with slightly more warmth felt in her feet, no varicosities, and tenderness around her knees. When palpating the patient's lower extremities, edema was present on each side, with the right side a little more pitting than the left side, which was a 1+. When checking patient's capillary refill in her fingernails and toenails, it was under 2 seconds, which is considered normal. Lastly, patient's pulses were all palpated and given a score on a scale of 0 to 4+. Upon palpation of her pulses, these are the grading values I got for each. Left temporal, 1+, right temporal, 2+, left carotid, 1+, right carotid, 2+, left brachial 1+, right brachial 1+, left radial 2+, right radial 2+. Femoral pulses were not taken. Patient's popliteal pulse was unable to be graded because of her request to not do so due to tenderness in her knees. Left posterior tibial 1+, right posterior tibial 1+, left dorsalis pedis 2+, right dorsalis pedis 2+. One pertinent system to study in a patient with hypertension is the respiratory system. With patients' chronic hypertension and obesity, her heart is under much more stress, having to pump out blood much quicker than the typical person. In an article about obesity and its effects, it explains why monitoring my patient's respirations would be vital. With the, quote, mass-loading effect of fat, it requires an increased respiratory muscle force to overcome the excessive elastic recoil and associated increase in elastic work of breathing, end quote. My patient's compromised cardiac output and excessive weight not only put her at a high chance of finding trouble breathing, but also, if left unrecognized, could lead to dangerous breathing disorders while sleeping. The other pertinent system to be assessed in my patient would be the integumentary system, as it links to the issues in her peripheral vascular system due to her hypertension and diabetes. Patient had reported having an ulcer, which had healed, and because of her wheelchair-bound status and chief complaints, patient is at a high risk of contracting more pressure ulcers. David J. Margolis and his colleagues studied what medical conditions are risk factors for getting pressure ulcers in the outpatient setting. Their results had found that the conditions significantly associated with the development of an ulcer were, quote, congestive heart failure, chronic obstructive pulmonary disease, and diabetes mellitus, end quote. My patient has diabetes mellitus and cardiovascular disease, and this research confirms that doing an integumentary exam would be essential in reducing the high-risk chance my patient has of contracting a pressure ulcer. Thank you.